Welcome to the deep dive. Today, we're jumping into something really core to how we function, the lungs, specifically that critical dance between ventilation and perfusion.
It's a fantastic topic because, gas exchange itself, it's simple diffusion. We're making it efficient. That all comes down to balancing air movement, ventilation, and blood movement, perfusion.
We're drawing from Boron and Boulpaep's Medical Physiology today, aiming to really unpack this dense material.
Exactly. We want to break it down step by step, not just the what, but the why it matters, especially when things go wrong, clinically speaking.
Okay, let's get into it. By the end of this, you should feel pretty solid on how your lungs keep things running. So ventilation first, air movement, basically getting air from the atmosphere down into those tiny lung sacs, the alveoli.
Right, convective movement.
But here's the interesting part right away. Not all the air you breathe in actually gets used for gas exchange, does it?
No, that's exactly right. We talk about total ventilation, sometimes called minute ventilation, which is just, how much air you move per minute. So maybe half a liter per breath, your tidal volume, times, say, 12 breaths a minute. That's 6 liters total.
Sounds like a lot.
It is, but here's the catch. Maybe 30% of that, around 1.8 liters per minute, is just ventilating what we call the anatomical dead space. It's wasted in terms of gas exchange.
Wasted. Okay, walk me through that. If I take a 500 milliliter breath, where does that 30%, where does it go?
Okay, picture that 500 millimel entering. The first, maybe 150 millimel, just fills up the pipes, basically. Your nose, your throat, trachea, bronchi.
The conducting airways.
Exactly. No gas exchange happens there. That's your anatomical dead space. Only the last 350 milliliter of that fresh breath actually reaches the alveolar where the magic happens.
Oh, okay. And then exhaling.
Same idea, but in reverse. The first 150 milliliter you breathe out is actually that fresh air that was sitting in the dead space. Only the last 350 milliliter is the stale air coming from your alveoli.
So the useful part, the air actually doing the work, that's alveolar ventilation.
Precisely. Alveolar ventilation is the fresh air reaching alveoli or stale air leaving them. The air just shuffling back and forth in the dead space, that's dead space ventilation. Total ventilation is just the sum of the two.
This constant refreshing means the gas levels in the alveoli don't swing wildly.
Right. They fluctuate, but only by a few millimeters of mercury for oxygen and CO2 through the breath cycle. It's a relatively stable environment down there.
So how do we actually measure this dead space? I mean, how did they figure out it's around 150 milliliter?
Well, back in the 40s, Ward Fowler came up with a really clever method using nitrogen washout.
Nitrogen washout, okay.
Yeah, so imagine you're breathing normal air, your lungs are full of nitrogen. Then you take one single breath of 100% oxygen, 0 nitrogen.
Got it.
Now, as you exhale, you measure the nitrogen concentration. If it were perfect, you'd see 0 nitrogen first, that's the dead space air, the pure oxygen you just inhaled. Then, boom, a sharp jump to the high nitrogen level from your alveoli.
But it's not a sharp jump, is it?
No, because there's some mixing at the boundary. So you get this sort of S-shaped curve on the graph as nitrogen concentration rises. Fowler figured out you can calculate the dead space volume by looking at the shape of that S-curve, essentially finding the point where the initial no nitrogen part balances the rising part.
Clever. And there's another method using CO2. You mentioned that gives us something called physiological dead space.
Yes, Christian Bohr used CO2, similar idea. Room air has basically no CO2, alveoli have lots, so you measure the expired air that's CO2 free.
Okay.
But here's the really crucial difference. Fowler's method gives you the anatomical dead space, the physical volume of the conducting tubes.
Right.
Bohr's method measures physiological dead space. That includes the anatomical dead space, plus any alveoli that are getting air but aren't getting blood flow. We call that alveolar dead space.
Alveolar dead space. So ventilated but not perfused.
Exactly. In a healthy lung, anatomical and physiological dead space are pretty much the same.
But in disease.
Ah, yes. Think about a pulmonary embolism. A clot blocks blood flow to a part of the lung. Those alveoli still get air, but no gas exchange can happen. They become alveolar dead space.
So Bohr's method would pick that up.
It would show an increase in physiological dead space compared to the anatomical dead space. Fowler's wouldn't change. That difference is a huge diagnostic clue.
Okay, that really clarifies the wasted ventilation idea. Now, how does this all tie into CO2 levels? You mentioned alveolar ventilation.
Right. There's a really fundamental relationship here. Your alveolar PCO2, the partial pressure of CO2 in your alveoli, is inversely proportional to your alveolar ventilation.
Inversely proportional, so more ventilation.
Lower PCO2, you're blowing off more CO2.
Less ventilation.
Higher PCO2, CO2 builds up because you're not removing it fast enough.
Okay, so give me an example. What if I say double my alveolar ventilation? Hyperventilating.
Okay, so your ventilation goes from maybe 4.2 liters per minute to 8.4. Your body's still making CO2 at the same rate, but you're clearing it twice as effectively.
So my PCO2 drops.
Drops by half, maybe down to 20 millimeters of mercury instead of the normal 40. That causes respiratory alkalosis.
And that's why you feel dizzy.
Exactly. Alkalosis constricts blood vessels in the brain. Less blood flow, dizziness.
And the opposite, hypoventilation.
If you have your ventilation, PCO2 doubles, up to maybe 80. That's respiratory acidosis. And clinically, you can see things like malignant hyperthermia, where metabolism goes into overdrive, producing way more CO2, which can overwhelm even normal ventilation and cause acidosis.
Makes sense. What about oxygen, PO2? Does that just follow ventilation too?
It does, generally. Increased ventilation, and your alveolar PO2 rises, getting closer to the PO2 of the air you breathe in.
But there's another factor. The respiratory quotient.
Yes, the RQ. That's the ratio of CO2 produced to O2 consumed by your metabolism. It depends on what fuel you're burning.
Like carbs versus fats.
Right. For pure carbs, RQ is 1 CO2 made for every O2 used. For fats, it's lower, maybe 0.7 or 0.8. This RQ value gets factored into the alveolar gas equation, which lets us predict the exact alveolar PO2 based on ventilation and metabolism.
Okay, so we've got the overall picture. But you mentioned earlier, ventilation isn't the same everywhere in the lung, is it? Especially when standing.
No, it's definitely not uniform. Gravity plays a big role. When you're upright, the base of your lungs actually gets more ventilation than the apex, the top.
That seems counterintuitive. Why?
It's because of the weight of the lung itself pulling down. This creates a gradient in the pressure outside the alveoli, the intrapleural pressure, or PIP.
Okay.
The PIP is more negative, meaning more suction, at the apex. This pulls the apical alveoli open more at rest. They're already quite stretched.
Like an already inflated balloon.
Exactly. It's harder to inflate it further. It's less compliant on that part of its pressure volume curve. But at the base, the PIP is less negative. Those alveoli are less stretched at rest, more squished.
So they have more room to expand.
Right. They're on a steeper, more compliant part of their curve. So when you take a breath, that same change in pressure inflates the base alveoli more than the apical ones. More volume change means more ventilation.
Fascinating. So if I stood on my head,
The whole pattern would flip. Ventilation would be better at the anatomical apex, which is now the bottom.
and I guess lung diseases could really mess this up.
Absolutely. Things that make the lungs stiff, like fibrosis, reduce compliance overall. Obstructive diseases like asthma or COPD increase airway resistance. Both can make this non-uniformity of ventilation much, much worse. Some areas might barely get ventilated at all.
Okay, that covers ventilation pretty thoroughly. Let's switch gears to the other side. Perfusion. The blood flow.
Right. Perfusion through the pulmonary circulation.
And the big difference here is pressure, isn't it? Compared to the rest of the body.
Huge difference. The pulmonary circuit handles the same amount of blood flow per minute as the systemic circuit, your entire cardiac output, but it does it at incredibly low pressure.
Wait, how low?
Mean pressure in the pulmonary artery is maybe 15 millimeters of mercury. Compare that to the aorta at around 95.
Wow.
The driving pressure, the pressure difference pushing blood through the lungs, is only about 7 millimille Hg. Systemically, it's over 90 millimille Hg.
Why so low? Is there an advantage?
Oh, absolutely critical. It prevents fluid from being forced out of the capillaries into the alveoli. High pressure would cause pulmonary edema fluid in the lungs. Plus, the vessels themselves are built for it. They're wider, shorter, much less muscular, and incredibly stretchy, very compliant. Low resistance is the name of the game.
You mentioned stretchy, compliant vessels. How does just the amount of air in my lungs affect the resistance to blood flow through those vessels?
Another fascinating interplay. It depends on the type of vessel. You have alveolar vessels, like capillaries, right next to the air sacs, and extra-alveolar vessels, larger ones running through the lung tissue.
Okay.
When you inflate your lungs to a high volume, the alveoli expand and actually stretch and flatten the tiny alveolar capillaries around them. That increases their resistance.
It washes them flat.
Pretty much. But at the same time, that lung inflation makes the intrapleural pressure more negative, which pulls open the larger extra-alveolar vessels. That decreases their resistance.
So one goes up, one goes down.
Exactly. The overall pulmonary vascular resistance, or PVR, ends up having this kind of U shape when plotted against lung volume. It's highest at very low and very high lung volumes,
And lowest.
right around your normal resting lung volume, your functional residual capacity, or FRC. The system is optimized for normal breathing.
Okay, that's clever. What about when blood flow itself increases, like during exercise? Doesn't pressure have to go up then?
It goes up a bit, but much less than you'd expect because the pulmonary circulation has these amazing passive ways to decrease its resistance further. Recruitment and distension.
Recruitment and distension. Explain those.
Recruitment is like opening up new lanes on a highway. Capillaries that weren't carrying much blood before, especially towards the top of the lung, get recruited and open up to handle the extra flow. More parallel pathways means lower overall resistance.
Okay, makes sense. And distension.
Distension is just the vessels that are already open getting wider, stretching out more because of the slightly increased pressure and flow, like making the existing highway lanes wider. Both mechanisms together mean the lung can handle maybe 3 or 4 times the resting blood flow with only a small rise in pressure.
Remarkable adaptability. Now here's a really strange one. Low oxygen. Hypoxia. Everywhere else in the body, hypoxia makes blood vessels dilate, right, to get more oxygen.
Correct. Systemic vasodilation.
But in the lungs, it's the opposite.
Exactly the opposite. Hypoxia is a potent vasoconstrictor in the pulmonary circulation.
Why on earth would it do that?
It's a brilliant local control mechanism. It matches perfusion to ventilation. If an area of the lung isn't getting much oxygen, maybe because the airway is blocked, you don't want to send blood there, it would just bypass the lungs without picking up oxygen.
Ah, so constricting the vessels there diverts the blood.
Precisely. It shunts blood away from poorly ventilated areas towards areas that are well ventilated, where the oxygen levels are higher. This optimizes gas exchange for the lung as a whole. It's called hypoxic pulmonary vasoconstriction, or HPV.
And this is a local effect.
Primarily local, yes. It seems to be a direct response of the smooth muscle in the vessel wall to the low PO2 in the surrounding alveoli. High CO2 and low pH also cause some vasoconstriction, but hypoxia is the main driver. Nerves and hormones, much less important here.
Okay, that explains the why. Now, just like ventilation, perfusion isn't uniform either, is it? Gravity again.
Gravity again, and its effect is even more pronounced on perfusion than on ventilation. Blood flow is significantly higher at the base of the lung compared to the apex when you're upright.
Steeper gradient for blood flow. How do we conceptualize that? I think I remember hearing about lung zones.
Yes, the West zones. It's a way to understand how the interplay between different pressures affects blood flow at different heights in the lung. We compare alveolar pressure, PA, pulmonary arterial pressure, PPA, and pulmonary venous pressure, PPV.
Okay, lay them out for me. Zone 1.
Zone 1 is right at the very apex. Here, potentially alveolar pressure could be higher than both the arterial and venous pressures, PPA, PPV. Think of the air pressure squashing the capillaries completely shut.
No blood flow.
Essentially none. But, and this is key, zone 1 doesn't normally exist in healthy resting lungs. Arterial pressure, even at the apex, is usually just high enough to overcome alveolar pressure. You might see zone 1 conditions in hemorrhage where blood pressure drops drastically, or maybe with positive pressure ventilation pushing PA up.
Okay, so not normal. What about zone 2?
Moving down from the apex, you hit zone 2. Here, arterial pressure is now high enough to exceed alveolar pressure, but alveolar pressure is still higher than venous pressure, PPV.
What does that mean for flow?
It creates a weird waterfall or sluice gate effect. Flow depends on the difference between arterial pressure and alveolar pressure, not the usual arterial-venous difference. As you go further down zone 2, arterial pressure increases due to gravity, the pressure difference gets bigger, and flow increases. More vessels are likely recruited here too.
Okay, then zone 3.
Zone 3 is the largest part of the healthy lung, the middle and lower regions. Here, both arterial and venous pressures are higher than alveolar pressure, PPA, PPV, PA. The capillaries are held wide open.
So flow's continuous.
Continuous and determined by the arterial-venous pressure difference like usual. As you go down zone 3, both PPA and PPV increase due to hydrostatic pressure. This causes the already open vessels to distend even more, further lowering resistance and increasing flow. Distension is key here.
So flow increases all the way to the bottom.
Almost. There's a subtle zone 4, sometimes described right at the very base. Here, while the alveolar vessels are wide open, like zone 3, the extraalveolar vessels might get slightly compressed by the less negative intrapleural pressure near the diaphragm. This can slightly increase their resistance, causing flow to peak just above the extreme base, and then fall off a tiny bit.
Wow. Okay. Zones 1, 2, 3, and maybe 4. It's all about those pressure relationships.
Exactly. And remember, they're physiological zones, not fixed anatomical lines. They shift with breathing, exercise, posture.
Right. So we've got airflow, ventilation varying by height, and blood flow, perfusion, varying even more by height.
Yeah.
What truly matters is putting them together, right? The VQ ratio.
The VQ ratio, that's the money shot. The ratio of ventilation V to perfusion Q in any specific lung region is what ultimately sets the local gas concentrations, the PO2 and PCO2 in the alveoli and the blood leaving that region.
So it's a balancing act.
It is. Think of it like a sink. Ventilation is the water coming in from the faucet. Perfusion is the water going out the drain. The water level in the sink is the alveolar PO2. Okay. If ventilation is high relative to perfusion, high VQ, faucet on full, drain partly blocked, the water level, PO2, rises towards the level in the pipes, inspired air. CO2 gets washed out easily, so PCO2 is low.
And if perfusion is high relative to ventilation, low VQ.
Faucet trickling, drain wide open. The water level, PO2, drops towards the level in the sewer, mixed venous blood. CO2 isn't washed out well, so PCO2 is high.
Got it. And since perfusion falls off faster than ventilation going up the lung,
the VQ ratio is lowest at the base and highest at the apex.
So the apex acts like a high VQ unit.
Exactly. High PO2, low PCO2 up there. Looks more like inspired air.
And the base acts like a low VQ unit.
Right. Lower PO2, higher PCO2 down there. Looks more like mixed venous blood. You can actually plot all these possibilities on an O2-CO2 diagram. It's a curve connecting the point for inspired air, infinite VQ, to the point for mixed venous blood, 0 VQ. Every region of the lung sits somewhere on that curve depending on its local VQ.
Okay, but what happens when things go really wrong? When VQ gets totally mismatched? The extremes.
Right. The two big extremes are alveolar dead space and shunt.
Dead space again, but alveolar this time.
Yes. VQ approaches infinity. Ventilation without perfusion, like our pulmonary embolism example. Air goes in and out, but no blood flows past. Gas exchange is 0. The air in those alveoli just equilibrates with inspired air.
Does the body try to fix it?
It does. That wasted ventilation leads to low CO2 locally, causing respiratory alkalosis. This triggers local bronchoconstriction, trying to divert air away from that useless area. And the lack of blood flow means less surfactant production, making that area stiffer, less compliant, further reducing its ventilation. Smart, huh?
Very. Okay, what's the other extreme? Shunt.
Shunt is the opposite. VQ approaches 0. Perfusion without ventilation. Blood flows past alveoli that aren't getting any fresh air. Maybe an airway is blocked, or alveoli have collapsed, atelectasis.
So the blood doesn't pick up oxygen or drop off CO2.
Exactly. It's like a shortcut shunting venous blood directly into the arterial side without getting oxygenated.
And the compensation.
Hypoxic pulmonary vasoconstriction. That low oxygen around the unventilated alveoli triggers the local vessels to constrict, diverting blood away from the shunt area towards better ventilated parts of the lung. It's the lung's primary defense against shunt.
So even if my total ventilation and total perfusion for the whole lungs are normal, having lots of areas with really high VQ and other areas with really low VQ is bad.
Very bad. Significant VQ mismatch, even with normal overall numbers, always impairs gas exchange. It leads to both respiratory acidosis, high CO2, and hypoxia, low O2, in the arterial blood.
Always both. Why? Let's take the shunt example again, the blocked airway.
Okay, pure shunt in one lung. The blood flowing through that lung remains venous blood, low O2, high CO2. This mixes with the perfectly oxygenated blood from the good lung.
So the final mix.
The final mix will definitely have low oxygen, but why is the hypoxia often so severe, and why is it hard to treat with extra oxygen? It comes back to hemoglobin.
The oxygen carrier.
Right. Hemoglobin in the blood from the good lung gets almost fully saturated, maybe 98, 99%. Even if you breathe 100% oxygen and raise the PO2 in the good lung sky high, you can only saturate that hemoglobin to 100%. You can't add much more content.
Because the hemoglobin is already nearly full.
Exactly. It's like trying to cram more people onto an already packed bus. So that highly saturated blood mixes with the very desaturated blood from the shunted lung, and the average oxygen level ends up significantly low. The shunt blood poisons the arterial oxygen content.
And the CO2.
The CO2 situation is often less severe with pure shunt because the good lung can often increase ventilation enough to blow off extra CO2, compensating somewhat. But the hypoxia from shunt is notoriously difficult to correct just by giving more oxygen.
That's a critical point.
Yeah.
How do doctors figure out if a patient's low oxygen is due to VQ mismatch or shunt?
One key tool is the A gradient, the alveolar arterial oxygen gradient.
The difference between calculated alveolar PO2 and measured arterial PO2.
Exactly. Normally it's small, maybe 5-15 milliprios, but in any kind of VQ mismatch, including shunt, that gradient widens. More oxygen in the alveoli isn't making it into the blood.
Okay, a wide A gradient points to a problem. But how do you distinguish bad VQ mismatch from a true shunt?
The classic test is to have the patient breathe 100% oxygen for a period. If the low arterial PO2 corrects significantly, it suggests the problem was mostly low VQ areas that could be overcome by the high inspired oxygen. But if the arterial PO2 stays stubbornly low, even on 100% oxygen,
Then it's likely a significant shunt.
precisely. Because, as we said, even 100% oxygen can't adequately reoxygenate the blood that completely bypasses ventilated alveoli. That failure to respond to 100% O2 is a hallmark of a large shunt.
Okay, wow. We've really unpacked a lot there. The whole dance.
Yeah.
Getting air in, getting blood past, and crucially matching the two. Dead space, zones, VQ ratios, shunt.
It's intricate, but it makes sense when you break it down. And understanding these principles is it's fundamental for clinical medicine. So many respiratory diseases boil down to problems with ventilation, perfusion, or the matching between them.
You really start to see how diagnosing breathing problems relies heavily on knowing how this system's supposed to work and how it breaks.
Absolutely.
Yeah.
Knowing the why behind the physiology gives you that diagnostic power. And remember, even the most complex topic is just a series of smaller steps. You build the understanding piece by piece.
Definitely. And for everyone listening, you're part of the Deep Dive family now. You absolutely have what it takes to master this stuff. Keep reviewing, keep connecting the dots.
You really do.
So here's the final thought to chew on. The body has all these amazing ways to compensate for VQ mismatch, hypoxic vasoconstriction, bronchoconstriction, thinking way out there. What might be a future evolutionary step? What could make our gas exchange even more resilient, maybe against extreme altitudes or new lung diseases? Something to ponder.